KWCO-FM, Chickasha. It's time for news.
Can you just give us a little opening statement about what's going on here at Grady Memorial?
Well, the hospital's been in a fairly urgent turnaround situation because of the recent requirement that our CMS surveyor said that we have to temporarily close the operating rooms due to high humidity levels that we've had in the central sterile area. The challenge we have had in our state of Oklahoma, we basically have never had high humidity levels. We've been having to add humidity our entire year for 20 plus years of this hospital. But now, with all these rains, the air has got a lot of high humidity, and our current air handler unit does not have a dehumidifier in the building. The previous life safety code inspector 3 years ago, when we approached that issue, when we called them when we have high humidity, his recommendation was just to put a portable dehumidifier in the central sterile area and the decontam area. It's not where patients are. Pull out that extra moisture and keep our levels in control. But we were told by the CMS surveyors that they won't allow a portable unit, and that is not approved. And because our unit doesn't have a dehumidifier in it, we can't operate the central sterile because it'll get too high a level past the minimum or the maximum standards, and we're stuck. So we couldn't meet the standard, and we couldn't ensure, not that we've had any, we already have very low infections, but their concern is high humidity levels could increase the possibility of organism growth, and then we would put potentially people at risk if we kept using that central sterile. So we're stuck. We have to replace that air handler, and it's going to take us time to find the specs to get it identified. It's a significant amount of money, but that's not the biggest issue right now. But all of the work, the engineering work, and the installation will take time, and the state wants to approve our plans and the unit to get that installed, as well as then some other things that happen to go in the operating room while they're at it, which are, again, we haven't changed that in the hallways of in our central sterile suite. We have a number of operating rooms, and we have the sterilizer area, but we have not in the operating rooms themselves, but in the hallways. They want us to change the ceiling of that operating room. It's been there for 30 years, and we have limited time to get this done. So all these little add-ons they want us to buy or replace is going to take us time, and we have to have their approval before we can get it accomplished. And so it's kind of a cascading of issues. And unfortunately for us, a number of rural hospitals have been asked to do these same kind of things in the operating rooms. A few that come to mind are Bristow's having the same issue, Hobart had the issue, Pauls Valley had the issue, even Anadarko, who's working with us. And unfortunately, when CMS cites standards, they're prohibited from giving us what they call advice. They just say you either meet or don't meet the standard. And so what we've reached out to the Department of Health, the Deputy Secretary of Health, and the survey team, saying we're a small hospital. We don't have unlimited consultants and money to be hiring experts. Can you please help us what do we need to do to minimize the amount of money that we have to do to get this safe or up to their standards and implement those changes? And they were very nice, but they said, we don't give advice. Those are your decisions. We just inspect and enforce the code. And that's not what a CEO of a hospital wants to hear. We need some support, and so that's why we reached out to Senator Justice, who's already been very willing to assist. I have a meeting with Senator Inhofe's health aide conference call, and then in fact we have a short meeting with Representative Tom Cole when he comes on his local visit Tuesday. So we're getting good support. Hank Ross is doing what he can because we know this is going to cost a substantial amount of money. But the big problem with it is that the surgery is the major positive revenue flow for this institution, and it will dramatically affect our ability to stay above water. And we still have employees that we're running to take care of, and so those expenses, our desire is to not lay all these employees off. We're going to try to find them some other things that we can do because it takes us too long to get those facts. So it's a major threat to our hospital.
So what was the timing of the ruling from the group? Did you just find out?
That would have been, I guess, the 18th. The basic thing would be that we were given this notice that they have this thing that they feel like an immediate issue, and they said you have to solve the immediate risk. So we put together a plan with our consultants and all the things we can do to kind of improve that, part of which was get Milton's air handling. We can get a new box fan to increase our cubic square feet flow of our air. We can reduce the humidity that way. We asked again, could we use that portable dehumidifier in the interim? And they rejected that. And the core is that all of the plans that we worked up and different changes that we could do, that we had proposed that we could do immediately, they said that's not acceptable. No comment. And we were forced to say that, okay, they basically gave us that you close your ORs or the entire hospital's existence, so the clinic, the emergency room, the med surg, that we wouldn't be eligible for participation in Medicare in less than 3 weeks. I mean, it's all about a risk. Brad Warden does our infection control here, and our physicians, you can talk to any of them, they're very proud of our infection rates and our infection control processes. Well, we could do better record keeping, we suppose. But basically, we have lower infection rates than other hospitals in this state. And they understand that, but it doesn't have to have a harm, it just has to have the risk. And so they said, well, you're not managing the risk. And the risk, in their judgment, is there without that dehumidifier.
How many ORs?
Well, we use 3. Altogether there's 5 rooms, but 2 of which we use just for storage of equipment. We basically use 3.
And how many surgeries do you normally do, say, on a weekly basis?
About 50.
So what's your potential revenue loss over, say, the 6 weeks estimated time that you're talking about?
Very back of the book, back of the envelope, easy numbers. We're trying to come up with that. What we're estimating is that, but we won't have certain expenses either. And so we'll be thinking the net of that revenue loss is around $370,000 a month by not having surgery open.
So that's basically more than 10% of your annual anticipated revenues about?
That's approximately of our total overall hospital operational revenue. That's about 15% of it. We're about at $1.2 million in total revenue. It varies based on busy months, sometimes one profile, so it's a substantial amount.
And then the cost of this unit will be?
The unit and and some of the other items like the ceiling, we don't really have all the pricing done, and so I'm trying to estimate that right now. So we really don't have that figure, but in my mind, we're talking probably a $450,000 expense.
Now, how large?
Labor,
how large is the cooler or air conditioning unit? Do you know?
I've had to check with my engineers, but I think it's a 10-ton unit.
All right. So what happens now with people that have had surgeries that have been scheduled over the next few weeks?
Well, all of our schedules, we've called all the patients that were immediate, and we've had to delay their cases and or try to arrange them to be done in other hospitals. And so we've been very active and working pretty feverishly on multiple fronts. We have been working with Duncan Regional Hospital. Their CEO and their medical staff have been very helpful. They're credentialing our physicians to go ahead and be able to do cases down there. It's not very easy for our patients to drive that far. Many of the complex cases, their operating rooms are like ours. They're sufficiently large and have the capability of doing those cases. Many of our smaller, non-extensive cases like carpal tunnel or simple orthopedic surgery or colonoscopies and things like that don't have to be in an OR. But we're trying to see if we can work out with our neighbors at Anadarko that our surgeons can 20 miles and do some of those cases there. And then the big issue would be, and then we're also doing the same arrangement. We're not going to have, at this point, we don't have our physicians going up there, but we're having we're trying to work arrangements to have our OB department essentially move to Duncan to take care of any C-sections. They do about the same number of deliveries we do. And so they have asked, and we're working with them closely to get our CRNAs to provide them extra support and basically provide our staff by remote control in Duncan with our CRNAs, our OB nursing staff, and some of our operating room staff because they need some extra help. And hopefully we can keep our employees employed, but it's not going to be all of them because they have a full crew already. Even though we've had multiple inspections from both Joint Commission and CMS before, but that the ceiling is not acceptable, that in the part of the hallway, and we're going to have to replace those ceiling tiles with a different type of ceiling. And that means we're going to have to, if they're going to weigh more because they're going to be solid surface. You can take any ceiling tile and wipe it off if you needed to. What we have in there in the hallway are the ceilings like this. Mm-hmm. Not exactly like this, but right. Similar. And that's, we're just going to have to do it. But those new tiles weigh more, and we're going to have to reinforce the structure. And in parts of that, we're not sure if there are other areas that they're wanting us to do a, that's what I call it, a monolithic ceiling. Because all of our operating rooms have monolithic, basically plaster ceilings. But that was all we've ever had, but now we have to do some of that in the central sterile area as well as maybe other areas. And so we're going to be getting their consult and advice of what we need to do and how much it's going to cost, and then we get it all done at the same time. The longest duration period is the air handler, though, because by the time we get it spec'd, get it ordered, get them to approve it, get it installed, and then resurvey it. That's why we're very concerned. It could be 6 to 8 weeks, we think, minimum, but it could be a little shorter. We just need their help, and that's why we're asking. Senator Justice has been at these meetings with us and helping me to understand the problem. We're wanting to do the right thing, but it's difficult because we're under the gun.
Now, where will the unit come from? You obviously probably haven't bought it yet.
We haven't even bought it. It'll probably
a few vendors that only have these, I guess.
Well, all of our current units are currently all trained air conditioners. Okay, so that's where we first contacted right off, and they were down the next day to kind of get us some kind of specifications of what we needed. And of course, then it was a little bit discouraging when they said, "Well, no, you can't just order it. You have to go ahead and get our approval, and have an engineering study to make sure that unit that you buy will meet the needs."
You have to get approval from
the state health department.
Okay.
Before we order it. So that's another delay, and we understand that that's their process.
So the engineers have been in to...
Well, yeah, we've already had that done, but we're going to have to probably, we were advised, I've talked to the Craig Jones of the Oklahoma Hospital Association, and so this issue is broader than just Chickasha. When other hospitals have had issues like this, what the Hospital Association is asking the state health department and in turn CMS, because it's the same person, but when they're here, I think I made that kind of clear, when they're inspecting us, they're wearing their federal CMS hat out of Dallas. When they're on the phone in their office, they can be an Oklahoma ally to help us do as best we can. But they're swamped. They're already overwhelmed because what's happening, and we've had multiple meetings with the state health department, is they have apparently are understaffed. But when a hospital currently changes anything in the design of the hospital, it doesn't really matter where, but it's particularly sensitive in operating rooms. You have to send your plans of what you're trying to do, even if it's just changing out that door. I mean, what's there to changing a door? But if you change the structure of that door, in any way, the door jamb or anything, they want to have architectural drawings reviewed by an architect that we hire. Then we send it to their architect that they hire to approve it. And if there's any changes, they send it back for changes. And that process has been taking a long time for even little items in the state. And a number of hospitals have had significant delays. What used to take just a week to get an approval from an architect has taken other hospitals 6 weeks to get on a minor change. We're very concerned about that. So that's why we're asking the state, can you expedite so that we're not at the end of the line? Because that's the current process, is kind of first in, first out. The hospitals and some of those facilities that we mentioned, they're taking 6 weeks, 8 weeks just to get easy answers. And so we're trying to encourage the state, we as the hospitals in the state, not King Spellman, to have some dual track, have the little minor things done so we can get the little issues fixed, and if it's major, then have kind of a two-track system. But right now, the state they're sensitive to it. The representatives say, we're hearing you, we're trying to come up with a thorough process, but they've been under the gun from the federal office of CMS to be more rigid and inflexible, shall we say, to Oklahoma hospitals, and that's been going on for 2 years. If we can use these other facilities, it's a huge burden, and it'll be a huge economic cost, but we think with the support of Duncan Regional, the hospital CEO at Anadarko, Norman Regional, that the bulk of our staff can be used there, but that's certainly difficult to do. What we don't know what's going to happen, but we're very concerned if this goes on very long, we won't be able to just last, because we don't have the cash reserves to stay without taking some action. And every employee knows that, but we don't, right now, we don't have that plan. It could be significant though, George.
What would be done at Norman Regional?
Well, Norman Regional would be some of our OB cases could go up there.
Okay.
Because we recognize that women, if they want to come to our OB doctors, but the two physicians are trying to make a choice. They can't be at both hospitals. So they're meeting with the medical executive committee tomorrow morning at Duncan and see if they can get that worked out, because that would be just one or the other. So, but Norman Regional said they'd be more than happy to help us. But looking at our county, a number of the women in the northern part of the county will probably go to Norman Regional because it's closer. So we're just trying to be pragmatic. We're in between both. We're right on the middle to Lawton too,
Right.
so far. But that's what we're trying to accomplish, because most of our staff lives south of the hospital, and so we think that would be a little easier. So they're trying to work out that they can deliver and do the major GYN cases at Duncan, and then we'll do minor cases at Anadarko if that can get worked out. The only thing I mentioned, we're going to be talking to economic development to help us to see if we can, because we are looking at this as saving jobs. So that was, because I'm not saying we're not. We know we have a major economic hit, and so we have to plan for that. And we're really working as quickly as we can to solve this unexpected deal. As I mentioned, it's frustrating my doctors where nothing's changed in that OR in the last 10 years, and it's just like a big wake up. Wow! Now all of a sudden we can't do what we've been doing well for years with the same equipment, the same site, and we're just kind of. But we're regulated by CMS, and they do run the rules, so we're very much at their mercy. And so that's why we needed to try to have some. We're going to be asking the state, maybe federal government, if they can give us some extra grants, because George, as you guys were aware, we had the vision to try to get a new facility. One of the big challenges to build a hospital is you have to have a significant amount of cash reserves so that lenders will loan you the money, like a down payment. And this will certainly push that into the future far. Those drawings are becoming dimmer in the future, but we know that we have a 58-year hospital. We know that, and there's no way around it. We need a replacement clinical space, not the whole hospital, but the clinical. And we have a good vision, and we have a good team, but this is going to be a certain, damaging it. We had a new recruitment. We have a new surgeon we were going to start just this next month, and he was going to come out next summer. So we got to get this done. By having good quality doctors, we might, we have to be realistic. They can't not earn a living. And if they're surgeons, that's what they do, and they can do a lot of things in their office. And almost every physician is showing their support, saying, "Well, we'll do what we can to help." But I think now I've already heard a number of them are, because they're employees of the hospital, as you may know, and so a number of them, including me, we're going to look at some voluntary just pay cuts because we need the money. And to their great tribute, they're already talking amongst themselves about what they can do, and that's very noble. Because other people need to hang in there. We're going to try to kind of hang in together and fight for this hospital, not just roll over and lay down. It's the biggest professional challenge I've ever had because of the scope of it and the things that I can't control. A number of the elements of timing. I can just hope and work hard and try to get this done.
And you've been in the business for how long?
Since 1980. So
35 years?
35 years, yeah. Just like I didn't get this gray hair out of nowhere. Yeah, all in rural hospitals too.
KWCO FM, Chickasha.